To begin with the case presentation straight on, there's a 55-year-old male with no history of tobacco consumption, had undergone a routine pre-operative workup for a planned surgery. On X-ray chest, a right lung nodule was detected. He was then further worked up with a bronchoscopy, which confirmed primary lung adenocarcinoma. A staging PET and MRI was done, wherein it was confirmed to be a T2A N1M0 lung adenocarcinoma stage 2B. Virendra, what next would be your line of workup?
MRI brain we have done, okay, non-metastatic. So looking at this cross-section imaging, I think it looks resectable lesion and T2N1. I would like to get the medicinal staging confirmed with something invasive, either EBUS or medistinoscopy, because it's a pretty T2 lesion plus central, plus on PET you have said N1 disease. That is one thing, and second thing is at the same time I will also get his functional evaluation like PFTD, LCO and 6-minute walk test, other workup like 2D echo and ECG.
Okay. So once that's done in your DMG, how would you approach this case, Vijay and Virendra both? What would be your options for this case? Okay, Ashay.
So basically, like if this is like operable, definitely a surgical oncologist takes call. But now we have a data, peri-operative therapy, which is already coming up. Usually, whenever we are planning, we usually look at the two things: either whether is immunotherapy feasible, immunotherapy non-feasible. Because that is something where definitely again, when we are looking in the terms of OS, definitely there is no data, but this patient usually we discuss with our surgical colleague. If they are comfortable operating upon, then we go ahead with the surgery first till this date, and then we take a call based on that.
Virendra, what would you do? You prefer surgery first for this patient or neoadjuvant therapy for this patient?
So we have a good evidence of neoadjuvant immunotherapy, which says good event-free survival and a better pathological response rate with neoadjuvant. But we do not have a very solid evidence whether that PCR or pathological response is translating into OS or not. That is one thing. Second thing about neoadjuvant immuno comes like about the affordability. If that is also one factor which we have to consider before thinking about neoadjuvant immuno. If affordable, yes, there is no harm in going ahead with neoadjuvant immuno. If not, then we would go ahead with surgery and then accordingly systemic therapy post-op.
So Dr. Govind?
$1 million question, right? Dr. Govind Babu sir, biopsy first. Means what is a biopsy?
No,
definitely we should have a molecular markers basically. Markers, so
yes.
Here we have molecular markers, like EGFR, ALK, definitely, because these are two situations where you will not give. So whatever sir was asking, basically you will have to do that first.
So I just wanted to go to the next question with sir only. So what are the criteria for patient selection when you consider neoadjuvant therapy? One of them you just highlighted of EGFR, the molecular markers.
So I think this underscores the importance of MDT. Because till now they would go to a surgeon first and surgeon would operate. So I think it's important that we have a FDT there, and we look for if there are any driver mutations. If they are not, then we will accordingly decide whether we'll give immunotherapy as a neoadjuvant. Get in discussion with the surgeon.
Yeah, this is the first time I have heard a medical oncologist saying that surgeon can go for surgery first, and a medical surgeon who has told me that it's a plus minus thing. So
just one thing. If the tumor is 3 cm and above, that is what we usually send the patient for neoadjuvant.
Yeah.
So that is something, because if patient is going to receive adjuvant, better to give it in neoadjuvant and then take up for surgery.
Fair enough. Fair point taken. It also helps actually for surgery in the future. So this is a review of the slide which Kushal has just gone through, current outcomes with immunotherapy in neoadjuvant setting. Of these trials, which one do you think is most practical and practically possible, sir? In our Indian scenario, which one is?
All of them are the same. If you look at the cost, pembrolizumab is a little more expensive. That is all.
So, would all of you be willing to use immunotherapy in the neoadjuvant setting, considering cost is not an issue? And what would be the choice, just like I said, Vijay?
I think
the question is whether we want to give neoadjuvant therapy or not neoadjuvant. So the question is not whether immuno has to be given. We have now good data that immuno has to be a part if the mutations are negative. So if the MDT decides that patient has to go for neoadjuvant therapy, and if the access to immunotherapy is not a question, immunotherapy will get added up if there is no mutations in the to the patient. Now my personal choice remains Checkmate 816 because it used only 3 cycles of nivolumab and there was no immunotherapy after that. Most of the others had used 6 months course. So it becomes more kind of
Easier,
economically
cheaper,
viable
yeah.
for at least for my patients. That's
Yeah,
why
so that was the next thing. So for out of the 2 out of 3, sir had said anything is okay. You prefer nivolumab. Anything specific for you, Ashay? Or
Yeah, nothing. So as Vijay said, I think there are various reasons we choose nivolumab. Definitely, if you look at the trial schema also, and plus accessibility also amongst all these 3 markers. I just wanted to ask to the surgeons basically. Now we have seen both there as neoadjuvant with chemotherapy and neoadjuvant with immunotherapy. So do you feel that there is a problem after during surgery if somebody has received immunotherapy and somebody has received chemotherapy alone?
Virendra?
So whatever we have heard, surgery becomes little bit difficult with immunotherapy as there is a response. If patient has a bulky node and if it is responding, the dissection along the vessels become little difficult. That is what we have heard. But if you see Checkmate 816, the results was little bit different than what we have been. So pneumonectomy rates were lesser with neoadjuvant immunotherapy. Our personal experience is only of 4 cases out of which 1 was inoperable. And it's okay, it is manageable, not that bad, but yeah, there is little bit problem along dissection along the vessels, especially pulmonary.
Do you think that would be a learning curve? Like initially
So-
when we used to operate esophagus after chemo,
so,
we used to be
correct.
comfortable.
So-
CTITs we were not
Yes.
comfortable.
So,
but then we had that learning.
that is
curve.
what is happening in
So
almost.
I think Virendra is the surgeon from the era where he has only operated post neoadjuvant.
We have seen a
I
difference.
have operated both
Both.
sides. So in esophagus, so it was a learning curve. And now we are very comfortable operating
Yeah,
post
sure.
NSCT. When we started doing post neoadjuvant chemo radiation, we were cursing the radiation oncologist. But now we are comfortable operating that even minimally invasive. So I think there is a learning curve, especially with minimally invasive surgery. And what we have found is that there is a rind of tissue which develops, a thickening of fascia over the pulmonary artery especially. So that is a little difficult to dissect at the fissure and hilum. And of course the nodes become very inflammatory and sticky. So these are the 2 problems. But I think with more and more patients receiving it, we should be able to circumvent it.
I have a very personal bias towards neoadjuvant therapy in most tumors. I feel that this is a window of opportunity for you to look at how these drugs work in the tumor. So I am a big proponent of neoadjuvant for all cancers. And I'm taking it as an extension from neoadjuvant chemotherapy for operable breast cancers. So I think soon it will come to the other areas as well.
Okay, so you prefer neoadjuvant chemotherapy even for very early stage lung cancer, sir, or you would?
That is my personal
Personal
bias.
bias, yeah, personal bias. Okay, one of the things which has been pointed out in Checkmate is cost. But considering these 2 studies, which is more applicable to real world, Vijay or Govind, sir? The AGN trial and the keynote 6-7. Sorry, blame AstraZeneca for this, okay? Don't blame me for this.
Operable lung cancers are few, and I am comfortable with the regimen of Checkmate 816, and so I have not used both of these. That's my.
Sir, your
Vijay's argument for that study is that you just give those 3 cycles and after that you don't follow, but all the others, there's an adjuvant component to it, so that adds on to the cost. But I have used pembrolizumab in neoadjuvant, so again each one of us has
Has
little
their own-
more experience with one drug because these are all new and
New.
as you know, operable lung cancers are so far and few.
yes, that is a trick, and we are hoping that changes with the more and
Yeah.
more of. Oh, so next question is, okay, immunotherapy is done. We've done these 3 trials and we have put them down as